Hi, my name is mo.azam. I'm an anesthesiologist in Florida. I've been in practice since 2003, and our group joined US Anesthesia Partners around 2014. Since then, I've been fortunate to serve along many of my partners and colleagues on our National Clinical Quality Committee. We have representation from all of our sister practices there, and the COVID-19 crisis certainly put us to the test and really brought out the best in all of us as we worked together, like many others in our profession, to come up with the best guidelines and recommendations for managing the disease, keeping our patients safe, and keeping ourselves safe. In the last couple of weeks, we really worked hard to come up with the next steps and look at testing strategies and a screening algorithm for restarting elective cases. In that process, we did an exhaustive literature review and came up with the presentation that I have here. And we talked to a number of outside folks from external to our organization, about 20 different other private practices and academic groups, and got a lot of positive feedback and thought that that collaboration was very useful and wanted to continue that here. So we got approval and went ahead and are going to go ahead and share this work product. We'll also post our literature review and our annotated bibliography. As a disclaimer, none of this is very prescriptive, shouldn't be construed as an official recommendation or protocol or guideline, but is really just a foundation of the literature and what we know today regarding testing, and one of many ways to think about how to move forward, not only with safety in mind, but also efficiency in managing the difficult and constrained PPE pipeline. And I'll go ahead and minimize the video here and run through these slides. And when we looked at this process, and as a disclosure, by the way, I don't really have anything else to disclose. I don't have any vested interest in any of the testing companies or other entities that are mentioned in this presentation. I'm a physician partner and I have an ownership stake like the other partners do in our company, which is a physician-owned and it's clinically governed by practicing anesthesiologists. There's about 4,000 clinicians in USAP and over 1,000 facilities. And so what we come up with from our National Quality Committee, although it has input from all of our representatives from component practices, it's again not prescriptive. It's very much handled locally and by the local quality committees to enact our best practices or recommendations. Further bioinformation is available publicly on LinkedIn, including my educational background. So when we looked at this, we realized that there was obviously a number of different ways to approach a screening algorithm for preoperative or pre-procedural testing. Now you've got your PCR tests, which we should all be pretty well aware of by now, and they look at the viral genetic code or RNA, also known as a molecular test or nucleic acid test. And then you've got what's coming on the market and increasingly and more commercially available, but also in higher accuracy, the serology or antibody tests. Now these tests are looking not at the viral component, but your immune response against that, so they're detecting those proteins or antibodies. What was concerning in the initial release of a lot of these tests was that many of them were approved under emergency use authorizations and didn't have a lot of validation data. We're a little dubious with the sensitivity and specificity, but a lot of that is changing, and we really sought to kind of look at the next steps in this process. One great resource is the Foundation for Innovative New Diagnostics, the acronym FIND. Their public website has a tracking of close to 400 plus COVID tests. And you can reference those as you do your research into picking and choosing which test to use. Now, the PCR tests have been considered gold standard and have the recommendation from the societies such as ASA and the APSF for a couple of reasons. Their clinical accuracy is relatively high, but their laboratory or analytic accuracy is really great, many times 99 to 100% sensitivity and specificity. These tests are really good at detecting illness or virus early, including before patients have symptoms. And if we're going to be testing folks that are asymptomatic coming in for elective procedures, we're really going to have to use PCR tests as a crucial component of that. The challenge comes in is that their accuracy drops off when it comes to real-world specimen acquisition and a number of other factors. And the accuracy is dependent on some presence of viral material, and that viral material tends to be higher earlier in the infection and can wane afterwards. It also depends on how well you do the swab, and so the reports out there vary from 70 to 90% sensitivity because of that specimen acquisition. So although it's got a lot of good aspects, it's not the perfect test on its own. Serology tests have a variety of components: IgM, IgG, and IgA. For our purposes, we looked at what is becoming increasingly available with IgM and IgG tests. Your IgM is going to be your initial immune response against the virus and may take anywhere from 3 to 12 days to develop. Typically around 5 days you'll get a peak. And so because of that lag, these tests are not on their own useful enough for a screening program. But what's interesting is that could you use them in a combination with PCR tests to complement the drawbacks of PCR with the benefits of the serology test. IgG takes a little bit longer to develop, typically somewhere around 8 to 14 days for seroconversion. And there are questions and unknowns here as to how long that IgG is going to stay elevated and what that means in terms of immunity against reinfection. But for a screening algorithm, again, we're not as concerned on that. We're just looking to see, can we detect any virus or response against the virus in the early phases to screen folks out. Here's a cartoonish graph for illustrative purposes. The blue line being PCR, the green line being IgM, and the red line being IgG. And so our thought process was, is there enough of an overlap here where if we were to test or screen for all of these things, we could capture people a lot better in those early stages of infection when they may be shedding virus and transmitting the disease. The little graph at the bottom showing the test results, if one is positive, another is negative, and so forth, describes the various stages of infection from early on to the active phase to late stage and even convalescence. So our thought process here was importantly to do no harm. We want to limit disease spread in the population for a variety of reasons. There's a number of papers and articles on this topic that folks could be spreading the disease when they don't even know they have it. In the lay media, this was evident as it was published that up to 60% of the sailors, for example, on the USS Roosevelt had infection or tested positive without any symptoms. The Nature Medicine study cited here was also another good example. They looked at household transmission. For example, if someone was told they had the disease and to go home and quarantine and likely passed it on to somebody else in their household, retrospectively looking at that, they estimated about 44% of those infections happened to be passed to somebody else in their household, while the person, the index case, was asymptomatic. So again, a pretty significant concern that asymptomatic people can shed virus and pass it on. The other part of doing no harm is to protect our own fellow clinicians. The CDC's article and publishing on this is probably the most comprehensive for the U.S. Just a few weeks ago, where they described 9,000 plus infections just amongst U.S. healthcare personnel since February. And the third part of doing no harm is sometimes overlooked by our facility partners, surgeons, and so forth. It may not be as evident in their literature, but it's to protect the patient themselves. There's one study that had a number of flaws in it, but this isn't a disease that's had a ton of published material out there, so we have to take what information we know in this, we're only a few months into this. The Lancet study looked at early infections in Wuhan when there was a lot of undiagnosed patients that happened to be unintentionally scheduled for elective procedures and happened to develop COVID-19. In those cases, and this was a small study, about 20% mortality occurred in that group compared to 2.3% for all COVID-19 cases. So again, lots of issues with that paper, but nonetheless, there's enough concern here that we ought to be fairly careful and err on the side of caution and try to screen people as best as we can to not have them undergoing elective surgeries and procedures if they might have the virus or certainly if they have the disease. So our high-level points, we were trying to be ahead of the curve on this, and again we shared this somewhere around mid-April with our partner practices. We're basing this on our best understanding of the current available tests, which is evolving very, very quickly, and the current science, which is also evolving very quickly in this pandemic. We're very interested in the safety of our facility partners as well as our surgeons and of course our patients, and for all those reasons came to the conclusion that every elective procedural patient should be tested in an ideal world. But we have to be reasonable to accept a lot of latitude in the type and the timing of those tests, both because the science is changing very quickly, the technology and the availability of the tests are changing very quickly. In different markets, different tests are available and there's different lag times to get results. And so while we may put together a sort of best ideas around this, we have to figure out how to implement it locally. Quick refresher on testing basics, as again we put this information out to our fellow colleagues. And when you're looking at a test with published statistical validity, you have a sensitivity and a specificity, and you basically have 4 different outcomes there. Our concern around a testing strategy was really around the false negatives. Those would be patients that would test negative but have the disease, and that would be kind of the worst outcome. Obviously you're employing testing which has some cost to it, you miss the treatment opportunity, you risk the disease being spread. So you can come up with a false negative rate or estimated false negative rate based on the sensitivity of the test. But your real-world application of that really has to take into account your local prevalence of the disease. And with that information, you come up with your negative predictive value. So the key thing as you're evaluating tests is not only to look at that sensitivity, because the flip side of sensitivity is a false negative rate. For example, if you have a test with a 90% sensitivity, you'll have a 10% false negative rate. That's people that have the disease and tested negative. And again, your negative predictive value factoring in your local prevalence. So we really need to know our local prevalence if we're going to take some tests and deploy them and use them in a screening algorithm. So what's the prevalence? Well, it's all over the map, and here's some of the data around this. New York State, for example, had randomly tested 7,500 people at grocery stores and shopping centers and found about almost a 15% prevalence rate. The Stanford and LA County studies, that in Santa Clara and the USC LA County study, came up with rates that were around 4 to 6%. Both of those studies were criticized for some methodological issues as well as some challenges with estimations that they might have used. Nonetheless, it's another data point for us to think about and try to figure out what our local prevalence might be. The University of Miami also looked at another large urban area, in this case Broward County, and came up with similar numbers. The WHO has a couple of studies underway on this, Solidarity and Solidarity 2, and their preliminary information is that there may be a 2 to 3% prevalence rate, sort of writ large. Across the spectrum, you go from a low of just under 1% in the Iceland study to up to 50 or 60% in deeply endemic areas, for example, aircraft carriers or prisons. So it can be all over the map here. What is interesting here is that there is a lot of consensus that in all of these studies that a large number of folks could be positive but asymptomatic if you look at the right side here. And so we do want to be very cautious about that. How about our world? Well, we've got one published paper, a letter to the editor on this in the area of OB anesthesia. The folks at New York Presbyterian and Columbia University Irving Medical Center had already started to undergo universal testing for all the women that hit their L&D decks in early April. And over a 2-week period, they basically caught almost a 14% positive rate, 90% of those having no symptoms. So again, another data point that we should be very, very cautious regarding the potential for asymptomatic folks that have the virus. So if we take into account some unknowns on our prevalence and undergo a strategy of just PCR testing alone, we come to the conclusion that false negatives would still be a significant concern. So again, you take these tests with a very high analytical performance, 99 to 100% sensitivity, and in the real world setting, that clinical performance degrades a bit, because you've got issues around timing of sampling or specimen quality, such as the location or of the specimen acquisition. So nasopharyngeal swabs, which have been the mainstay in the last month or so, take that 99% sensitivity and drop it down to somewhere around 88%. Sputum would be great, but we're not going to be able to get that on asymptomatic folks. So in the real world, are we getting nasopharyngeal swabs? And maybe less than that, because as we see in some locations, patients are allowed to self-swab and return the samples. So you might be getting something that's less than ideal sample. So for all of these reasons, it's hard to estimate, but somewhere between maybe 80-85% sensitivity. So even if you said an 85% sensitivity, that would leave you with potentially 15% false negatives. And then you got to figure out, what does that mean locally? So you can go to these diagnostic test calculators publicly available on the internet. The links for this one is there. And in this case, I went ahead and plugged in, well, let's say I had a very low prevalence in where I live around Orlando, Florida, of just 1%. And the specimens with PCR, let's say it was about 80% sensitive, because I know here it's patients are being told to go ahead and swab themselves in many locations. A very high specificity of 99%. And so you might have a result like this, where you'd only be looking at 2 out of every 1,000 that could be what would be a false negative. So really sounds like a great result and a great way to test and use this for screening. in this environment, because that's basically 1 in 500 patients that might be a positive and yet test negative. If you go ahead and put in some higher numbers here, let's say a 5% prevalence with the same information, you come up with, let's say, 10 out of 1,000. So again, it sounds at initial glance to be a very reasonable way to move forward with a single PCR test. So you have to put this in context to your practice, and I went ahead and used the same numbers here, but I added a total sample size. Looking at, for example, a typical mid-size anesthesia practice in the US, doing around 40,000 cases a year. Let's say it's 20-something physicians in a care team model with around 30 or so anesthetists. So this would get us to around 50 clinicians. And now, if using the same numbers, you may be looking at potentially 80 patients in the course of the year, potentially 80 exposures to your 50 clinicians. All of a sudden, that 1 in 500 number doesn't look so good when you're talking about large numbers here of cases. So how do we improve upon that? Well, you got to make that sensitivity better. And one of the ways to do that is a combination PCR and serology antibody test algorithm. And there's been a couple of papers published on this which were intriguing to us. The first two that are cited there from a lab sense, and then the second two in a clinical sense. And in this instance, in these instances, these clinical studies were done early in the Wuhan infection, when the sensitivity of the RNA PCR alone was pretty poor, around 50 to 60%. But the combined dual testing improved that sensitivity to the high 90s. So when we have high quality, commercially available in large numbers, IgM ELISA assays, it makes a lot of sense to consider to use that in a dual testing strategy along with PCR. So when we looked at that cartoonish graph at the beginning, looking at PCR, IgM, and IgG, here's the graph that is in the paper that was cited on the previous slide. And you see there's a lot more overlap on these three lines. And again, the reason that we can improve the sensitivity fairly significantly here. So ultimately, clinicians are going to have to decide when they can trust those negative tests enough to take that next step, which is to maybe step back from all the enhanced PPE that we're reliant on. And our proposal was to consider a dual testing algorithm with PCR and antibody serology for all OR and procedural cases when it's available. And that would ultimately produce a much higher sensitivity, which would be more appropriate to screen large numbers of asymptomatic patients and really minimize those false negatives. And the reason to do this is has multiple good reasons. One is it's the only foreseeable way out of our high PPE burn rate. We've got to do this through higher fidelity testing. And then the other reason is that if we don't do this, and if we only rely on, say, screening by history or temperature, or only an imprecise single PCR test, we're going to be perpetually reliant on that enhanced PPE, those N95s and face shields and gowns and ventilator filters, detailed cleaning of our operative areas, as well as maybe even delays in between cases to properly do air exchange in the rooms. The other good reason to do a dual testing strategy is that if you use the serology tests, it can also help you gather the prevalence data. And you don't want just prevalence data in your state or even in your city. What you really want is very local information. So for me, for example, the prevalence data in Florida might be interesting. The prevalence data in Orlando would be helpful. But what would be really interesting and really helpful is what's the prevalence data for asymptomatic patients presenting for elective procedures at my facilities. Then I can take that information and plug that right back into those calculators I showed you and come up with a much more accurate risk calculation for my practice. So a word of caution around this is that the FDA had, again, produced a lot of rapid EUA approvals on some of these serology antibody tests. Some submitted entirely without validation data. So pick your tests well and pick them carefully. Choose ones that have described performance characteristics, are scientifically reviewed, and validated with well-standardized controls. Things are evolving very, very quickly in all of this. Some of these tests that come out early, as you look down this graph, had a really poor sensitivity, and even the ones in the 90s really wouldn't be functional for our purposes, and I'll show you why in a moment. What is interesting is that some of these companies, for example, Abbott and Roche, are coming out with tests that are claimed to have a very, very high sensitivity of 100% as a serology test, and also a very high specificity. And also, very importantly, are going to be, or they claim to be able to produce them in high numbers. Abbott is saying that they'll be able to conduct 20 million tests a month, and Roche saying up to 5 times that. The total procedural volume in the US is around 20 million cases a year. We could certainly be able to have the ability to test all of our cases going forward. So the reason that even a test with a 90% sensitivity is not good enough is because in a low prevalence environment here, you still get enough false negatives to be a problem and a ton of false positives as well. It's not until you get to the really high 90s, in this case 99%, that your false negatives and false positives drop off, and that would be improved upon even more with a dual testing algorithm. So things are changing really, really quickly in all of this. Even since we put this out to our partners in April, and just a week or two after that, Quest announced that they're going to be able to test patients directly for serology tests without even a physician's order. You can go directly online to Quest Direct, add to cart, pay your about $120, and get your blood drawn at any one of the company's 2,200 labs. And still waiting to hear on the sensitivity and specificity for their IgM test. But again, looks like we'll have multiple options coming down the pike here, whether it's doing a test in-house or sending a patient to Quest or LabCorp, or even tests that are now being mailed to the patient's homes, and they can do their sample and drop it back in the mail and get a result. So lots of ways to be able to test our pre-procedural patients. And again, as things are changing rapidly, the White House also updated their recommendations and a testing blueprint on their Opening Up America Again proposal. This just came out on April 27th, and also reiterated something that we thought made a ton of sense, calling for dual tests, again, to be able to improve that positive and negative predictive values compared to a single test. In this case, they were using a combination of dual antibody tests. So skip forward to the next slide. Our internal quality committee recommendations for our practices were here, that eventually when it's available, we would like to have folks consider trying to test almost everybody. Emergent cases, obviously, we don't want to delay, but if we have the ability in our local practices to do an in-house PCR test or a rapid test, that would make sense. We would take these folks that have an unknown risk, or we'd be treating them as a high risk, and with a single negative test, we could consider them, say, moderate risk. I'll explain our risk stratification on the next slide. Urgent cases, something similar, if it's possible to do dual testing because of availability in-house at your local acute care facilities, would make a lot of sense. And again, to be able to take folks and risk stratify them with a dual negative test here, you could probably even consider them to be low risk. The semi-elective and elective cases, again, lots of different options here. Doing testing in your facilities or send out, or even mailing to the patient's house, or having them go to a lab facility to get it done. Dual testing would, again, dramatically improve our risk stratification. Certainly a positive PCR or a positive IgM, and we would want to hold off on performing elective procedure. If you've got positive IgG, it's a little bit more challenging. It's a bit of an unknown still, a gray area. Because is that IgG reflecting, let's say, an infection that's only 2 weeks in? Or is it reflecting something that happened months ago? So you really got to go off clinical history there and asking the patient about any exposure history or symptoms. If you've got none of that, again, theoretically, you could be only 2 weeks into an infection or further out. So you probably want to advise that patient to come on back in a few more weeks, get retested, and if they're clear with both of those tests, makes sense that their infection is at least 4 or more weeks out, past the point of typical viral transmission and shedding. So the key part of this was to take our testing strategy and marry it to our PPE recommendations. If we've got a double negative test and we can consider that low risk because of the high sensitivity and low false negatives, we've got cases without aerosolization, for example, without airway instrumentation, then we could conceivably move to routine universal precautions on those cases. For now, for aerosol generating procedures, we would continue to use N95s and face shields until we gather, let's say, a month or so's worth of data on our local prevalence. And if that prevalence information is then in fact put into those calculators, we could certainly take a dual negative test with a low prevalence environment and have a very high sensitivity, a very low false negative, and decide locally, is that where we can move this top right box to green, to basically routine universal precautions. If we don't do that, we continue to live here in the middle boxes, which is a moderate risk. A single negative PCR test, and even as the ASA guidance has put out, that still warrants continued N95 usage and additional PPE because of the false negative rate. So this is all fine as we have restarted elective procedures today. We would like to figure out how to move to this top box in the next few weeks and the next coming months. And one of the important reasons for that is we don't know what's going to be coming down the pike with PPE shortages. This really informative work was done by the Get Us PPE group, a number of physicians from MGH, Oregon Health Sciences, and some other academic institutions. They surveyed almost 1,000 facilities across the country and asked for a breakdown by N95s, face shields, and so forth, and also a geographic breakdown. And a surprising answer of how a lot of folks had very little supply, or maybe a week or 2 weeks supply. And this poses some significant concerns because as the whole country is starting to come back online with elective procedures, we think that there may be risk to the PPE pipeline of what's going to be available. And those supply shortages could certainly come back in the next month or so. The other aspect of this is it's not just our healthcare environment that's going to be using up a lot of these resources, but the rest of the country is opening up in a variety of ways, whether it's mass transit, airline travel, restaurants, even barbers and hair places that are all going to be using N95s and a variety of other personal protective equipment and disinfecting wipes and so forth. and again may lead to some significant shortages again. So we've got to figure out how to move past our reliance on PPE in our initial ramp up. So as we think about ramping up, we should also think about the healthcare consumer sentiment around this. You know, folks are scared, as evident by this one survey of around 1,000 healthcare consumers. Only 15% said, you know, they'd be comfortable entering back into their local hospitals for a medical procedure immediately once restrictions are lifted. A lot of folks would feel more comfortable waiting some time. And I think our reassurance for those folks by a really robust testing strategy is really important here as well. So highest on their concern is getting sick from other patients or contacting COVID. But there's other factors at play there as well, including economic forces such as high deductibles and lack of insurance coverage, as so many folks have lost employment and their employer-sponsored health insurance. So our basic themes, we are starting back up in so many locations when facilities are getting out of the surge. We've got to have an adequate supply of PPE to do that, because relaxing PPE recommendations can only happen when you've got enough reliance on the tests in a low prevalence environment. We're not going to be able to completely drop PPE until our entire clinical teams are either immune through testing or vaccination, and that's going to be quite some time off. So again, as we look on the initial ramp up, we are doing emergent cases where we can do a single rapid PCR test if possible, but not delay those cases. And looking forward to the next month or two to try to have those collaborative discussions with our facilities to do dual testing if possible on everything else. And we proceed with a likely course, of course, following the general guidelines from ASA, ACS, AORN, and AHA, the American College of Surgeons guidance, which has been very, very well written, and the medically necessary time-sensitive scoring system. We think that we are going to continue with enhanced PPE at this time for every patient, and that we will have to eventually at some point try to move past that, because we can't live in just that moderate risk category. Eventually, we'd like to transition to double negative testing with both PCR and serology, and that would give us the higher sensitivity, the lower false negatives, and the collection of our local prevalence data, so that we can figure out our own calculations and make our own judgments on when it's safe to drop some of those personal protective equipment that we've been reliant on. So thanks for allowing us to share this. And again, I hope this is useful for folks out there, not only as we're trying to get our businesses started up again, but try to do what's right for our patients and try to keep our colleagues safe, and also try to keep our facility partners informed on the next steps that we might see coming at us in June and July, for example. Thanks.